Welcome to this video on pharmacogenomics. I am Dr. Brian Paulo, and this video will synthesize CPIC guidelines and Harrison's 21st edition for precision prescribing. Pharmacogenomics explores the genetic basis of precision medicine. We will discuss the fundamentals of genetic variation, Phase 1 and Phase 2 metabolism, pharmacodynamics, and G6PD deficiency, as well as clinical guidelines for CYP variants. The video is structured into three main parts: principles of genetic variation and drug response, genetic variants affecting pharmacokinetics, and genetic variants affecting pharmacodynamics. We begin with the principles of genetic variation and drug response. Genetic variation stems from distinct structural alterations, from single nucleotide polymorphisms to whole gene duplications. Clinicians must understand these molecular origins as they strictly determine the functional magnitude of the resulting metabolic phenotype. Allelic combinations dictate enzymatic activity, stratifying populations into four primary metabolizer phenotypes: poor, intermediate, extensive, and ultra-rapid metabolizers. Minor allele frequencies and functional effects of structural variants show profound divergence across the global population, as seen in this table of genetic variants. Next, we will focus on genetic variants affecting pharmacokinetics. Drug clearance occurs in two phases. Phase 1 enzymes modify lipophilic drugs, and Phase 2 transferases attach polar groups for renal or biliary clearance, resulting in the eventual excretion of the drug. Phase 1 and Phase 2 metabolic pathways rely on highly polymorphic enzyme superfamilies to clear lipophilic drugs. Phase 1 is predominantly CYP 450 dependent, and Phase 2 involves conjugation. This table highlights key genetic variants in Phase 1 drug metabolism pathways, their affected drugs, and the resulting clinical effects or phenotypes. Cytochrome P450 nomenclature is hierarchically classified based on precise protein sequence similarity, ranging from superfamily to family, subfamily, and the specific enzyme. The reaction mechanism of cytochrome P450 involves the enzyme catalyzing the oxidation of substrates, in this case RH, using O2, NADPH, and H+, to produce ROH, H2O, and NADP+. CYP3A metabolizes the greatest number of drugs. It is highly variable among individuals, with reduced activity observed in European and Asian populations, and greater activity in African populations. Genetic ancestry fundamentally alters population-level allele frequencies, necessitating ancestry-aware clinical dosing strategies. The CYP3A5*3 variant is overwhelmingly common in European and East Asian populations, making Poor Metabolizer the clinical baseline there. 3 cypriot pounds of 5 inches expressors require a 1.5 to 2-fold increase in starting tacrolimus dosage to achieve target immunosuppressive trough concentrations. The table shows specific recommendations based on phenotype and genotype. Tacrolimus, a calcineurin inhibitor and immunosuppressive agent, inhibits T-cell proliferation. It is used for kidney, heart, lung, liver, and hematopoietic stem cell transplant patients. CYP2D6 is second to CYP3A in the number of drugs it metabolizes. Poor metabolizers, common in European and African populations, have decreased clearance and increased steady-state concentration. Ultra-rapid metabolizers show the opposite effect. Codeine therapy is contraindicated for both poor and ultra-rapid metabolizers of CYP2D6 due to risks of fatal respiratory depression or lack of analgesia, as shown by the activity score thresholds. Variations in CYP3A5 and CYP2D6 mandate dose adjustments. For CYP3A5 and tacrolimus, expressors need increased starting doses, while non-expressors use standard dosing. For CYP2D6 and codeine, ultra-rapid and poor metabolizers should avoid codeine entirely. 2 cypriot pounds C19 poor metabolizers are common in Asian populations, affecting drugs like omeprazole and clopidogrel. PMs have a high cure rate with omeprazole, while clopidogrel requires bioactivation by this enzyme. This table outlines the clinical dosing recommendations for CYP2C19 phenotypes concerning clopidogrel. Poor and intermediate metabolizers require alternative P2Y12 inhibitors due to inadequate platelet inhibition. For CYP2C19 phenotypes and selective serotonin reuptake inhibitors, or SSRIs, dose adjustments are necessary. Ultra-rapid and rapid metabolizers may need increased doses, while poor and intermediate metabolizers may require reduced doses or alternative medications. DPYD encodes for dihydropyrimidine dehydrogenase. Variants in this gene carry a risk of toxicity with the anti-cancer drug 5-fluorouracil, as well as capecitabine and tegafor. Intermediate metabolizers should reduce the dose, and poor metabolizers should avoid the drug. We now transition to Phase 2 metabolism, which involves transferases for drug conjugation and clearance. Key transferase variants include TPMT, NAT2, and UGT1A1. TPMT bioinactivates 6-mercaptopurine. NAT2 slow acetylators increase the risk of drug-induced lupus. Reduced UGT1A1 function is associated with toxicity from irinotecan. For TPMT, dose reduction of thiopurines is recommended for intermediate metabolizers and alternative non-thiopurine therapy for poor metabolizers to prevent severe bone marrow suppression. This concludes our section on genetic variants affecting pharmacokinetics, covering both Phase 1 and Phase 2 metabolism. We will now explore genetic variants affecting pharmacodynamics. Genetic variants can affect drug targets, which include receptors, ion channels, enzymes, and transporters. The diagram illustrates various examples of how this affects drug response. One example is the effect of HLA-B times 1502 on carbamazepine, where a variant is associated with an increased risk of severe cutaneous adverse reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis. This table shows the strong association between HLA-B variants and severe cutaneous adverse reactions to drugs, including allopurinol, abacavir, and carbamazepine. The Clinical Pharmacogenetics Implementation Consortium, or CPIC, recommends testing for the HLA-B 1502 allele before initiating carbamazepine in high-risk populations, primarily those of Asian descent. Another example is the SLCO1B1 gene, which encodes an uptake transporter. The SLCO1B1*5 variant is associated with reduced statin uptake and a higher risk of muscle symptoms like myopathy. This graphic summarizes the effect of SLCO1B1 variants on simvastatin clearance, showing that decreased uptake activity can increase plasma concentrations, leading to a higher risk of adverse events. For simvastatin dosing, CPIC recommends a lower starting dose or an alternative statin for patients carrying 1 or 2 copies of the *5 allele to mitigate the risk of myopathy. Another critical pharmacodynamic variant is G6PD deficiency, or glucose 6-phosphate dehydrogenase deficiency, an X-linked disorder. G6PD deficiency is associated with hemolytic anemia upon exposure to certain oxidative drugs, such as antimalarials, sulfonamides, and dapsone. CPIC recommends avoiding certain high-risk antimalarials in G6PD deficient patients due to the risk of severe hemolysis, with specific recommendations varying by genotype. Genetic variants in G6PD require careful drug selection. For example, severe G6PD deficiency means primaquine is contraindicated, while milder deficiencies may allow for cautious use with monitoring. This table highlights key examples of pharmacodynamic gene variants, their associated drugs, and the clinical consequences, reinforcing the need for precision prescribing. In conclusion, pharmacogenomics integrates genetics into clinical practice for optimized drug therapy. It addresses the variability in drug response based on individual genetic makeup. The references for this video include foundational texts and the Clinical Pharmacogenetics Implementation Consortium guidelines. The principles and guidelines discuss support moving toward a more personalized and effective approach to patient care. Thank you for watching this video on pharmacogenomics.